So these are the leads, the limb and augmented leads with the electrodes. The views of the heart, this is from the guidelines, Appendix C. So looking at passing the electrical current, part of Einthoven's triangle, again, lead 1, left arm to the right arm. So again, lead 2 from the left leg to the right arm. Again, we're looking at the bottom surface of the heart, left leg to the left arm. Again, inferior surfaces. And then the augmented leads, those are the ones that appear upside down. So don't freak out when you see that on your ECG. And then here it is graphically. So this is a sample. You used to have to buy special paper for ECG. Now with the systems that we have, it'll print the ECG just on standard, office copy paper. So that's another thing too. Technology's gotten good. You don't have to use any type of special paper anymore. So if you look at the limb leads, you can see your PQRST. PQRST, you can see just how close they are to the heart. You're going to have a bigger amplitude. And then the AVR and the AVL, these are looking at the bottom surface of the heart. So remember, the impulse is going away, so that's why we have a negative deflection. When we get to these chest precordial leads, the one that is upside down is V1, because this is going to be on the right side of the sternum. And then all the rest of these are going to be on the left side of the sternum. V6 is going to be on your mid-axillary line. V2 is on the left side of your sternum, and then all of these fall away, in line underneath. We've got specific anatomical landmarks that we're going to look at for the electrode placement. So what does ECG tell us? So why is it a useful tool today? It's used a lot in exercise, in especially what's called clinical exercise testing. So someone thinks, they have chest pain. They may go in for an exercise test. They're going to do a treadmill test or a bike test with electrocardiogram while they're exercising. So not just a resting ECG. And so they will, during the test, they will increase the speed and grade of the treadmill usually, or the resistance on the bike, similar to a max test. We'll do the Bruce protocol, lab 5, and they'll also watch changes in blood pressure. So when a person has atherosclerosis, and we've got that coming up in a couple classes where we'll talk about what actually causes atherosclerosis, but a person's arteries are narrowed, your coronary arteries are narrowed, and they get reduced blood flow to the heart muscle itself, or the myocardium. And so that's called myocardial ischemia. So the demand for oxygen in the heart exceeds the ability to supply it. And so if someone's got a major narrowing of their arteries because of plaque, sometimes, they may have chest pain, especially with higher intensity exercise. When you look at the ST on the PQRST, that's going to look a little bit depressed. And so it may look perfectly normal at rest, and it may look perfectly normal with light exercise, but when a person goes to heavy exercise, they may see some ST segment depression, and that could mean that the person may have underlying heart disease, and they'll need to go for further testing. So it still is a very important test for that. Again, there's other things that they can do. We'll talk about these later in the semester. There are nuclear image testing where they can do this in combination with that, or they can do echocardiograms, which are ultrasounds of the heart. So there's quite a bit that they can do along with the ECG. But if someone thinks they're getting chest pain, or a doctor thinks the client may have heart disease, they're typically going to not only refer them for an ECG, but an exercise ECG, often called a stress test or graded exercise test, or GXT. So stress test, GXT, exercise test, stress test, they're all the same thing.